All right, finally doing it. We're finally talking about hypotension. And so I don't really have an objective. I think the ultimate objective is to figure out where we go and how we head through this. But perhaps we can sort of anchor ourselves in the reality that most of the time when we see hypotension, we're jumping into ACT. And I think perhaps I know AMK, you might get busy, so I'd love to use your brain power before it might be taken away from us. And I'm curious if you walk into a situation where a patient's hypotensive and you don't have to worry about the cause, you're sort of like, do. I'm curious what's in your like immediate action steps for somebody who's hypotensive.
Yeah, so I'm thinking about like the cause, but I think that's been taken off the table, the consequence, and then the baseline. So some of the consequences I'm thinking about are like, what do they look like? Obviously you need blood and blood pressure to perfuse your brain, to perfuse your kidneys, all the organs. And so I'm like really thinking about like, are they mentating? Like what has there been signs that this hypotension is leading to consequence? And then I like, I'm doing a quick like feeling their legs, feeling their arms, feeling like, are they cold? Are they warm? Getting a sense for that. And then chronicity, because it's very different if someone's kind of chronically hypotensive. I think we've all had the younger patients, maybe there's like some reason why, and they're kind of chronically low. And so it's not really a big change from baseline. So I think after that, it's kind of easier for me to assign like, is this a more chronic problem that maybe the person wasn't aware of, that is not causing consequence, or is this causing consequence? And then if it is causing consequence, I do feel like I need to understand a little bit more about it because it's kind of like, is this a heart problem? Is this a infection or distributive inflammation problem? Is this a volume or a bleed problem? Because I think all of those determine how I'm getting affected, or is it like a mechanical problem that needs a surgical like the mechanical problem, which I think a lot of those with exam and ultrasound you can make a lot of um, progress on a lot of times. If I think there's a reason why they can tolerate fluid, unless I think they're in cardiogenic shock, I'm going to be giving them, like fluid and getting it in quickly, making sure they have good IV access while I'm trying to like focus them, do a quick examination, figure out the background, how it informs the foreground, and make sure, like then kind of go down my decision trees like sepsis, appropriate fluids, like do they need pressors, mechanical problem, do I need help? Cardiogenic problem, do I need specific cardiology help, etc.
I think, guys, that's it. We're done. We don't need the rest of this time. That was absolutely superb. It was really interesting just to not just to track the details, and I think you filled in everything we're going to talk about, but also the order in which you went. And I find it fascinating when I'm sort of preparing to reflect with you guys that seasoned people like AMK always start with significance, like how serious is this? And as an early learner, it might be counterintuitive because you're seeing somebody seasoned say, I need to first establish the severity of this syndrome. And that, at first glance, might be counterintuitive. How could hypotension not be severe? How could someone be mentating and be just fine when they're hypotensive? And Masa, I'm curious. I mean, this is purely an intellectual exercise. We're just philosophizing here. Like, why do you think AMK is still open to the idea that somebody who's hypotensive may still be fine? What do you think is the root of that?
Um, I think, I mean, all I can think of is
Yeah,
maybe like someone who's like maybe athletic and who has
yeah,
just like chronic hypertension.
yeah,
Otherwise, maybe I don't know, they're on like medications. Maybe they're like their body adjusted to
yeah.
the hypertension.
Yeah. Yeah, if you zoom in on the details, what you're doing is really interesting. And so let's do like a back and forth building towards some attempt to understand why why the connection between hypotension on paper and in reality is a little bit different. So if you were to elaborate, Masa, maybe to somebody more junior to you, like in very simple terms, why do you care about hypotension? What is it about it that's so that gravitates attention?
Um, I'm uh I'm not really sure how to explain.
Yeah, that's okay. Give it a try. Why do you think it matters to you when somebody's blood pressure is going below a certain level? What's going to happen to the patient, you think?
Like, okay, so blood pressure is low.
Yeah.
Um, they're not like pumping enough blood to it to like the rest of their body,
Yeah.
including their brain.
Yeah.
So yeah, it can cause like maybe altered mental status,
Yeah, exactly.
just like loss of blood flow towards vital organs like the kidneys and so
Exactly.
on.
Exactly right. I think, you ended by saying, I think the most important thing. What you seem to care about the most is blood flow to, and you use this word vital organs, right? And I think, gosh, if you've ever been out in the cold, you'll realize that your fingers and toes get very poor perfusion in the New York snow. And we're fine with that. We're like, you know what? If my patient who has Raynaud's or person who has frostbites, like literally my toes go completely white and have no perfusion to them, that's fine for a little while. It's okay. So it's really actually all about the vital organs, right? And what you want to get is to make sure that the kidney, the liver, the gut, but most importantly, the brain um, gets enough oxygen and glucose to function. And if you ask yourself, how do you go about making the judgment that the brain may not be getting enough blood? I think the ideal scenario is that you would put a catheter in one of the major arteries going to the brain and measure the blood pressure there. You would also get a more accurate sense of what blood pressure is necessary to perfuse this brain in front of you. And those two things are probably the most important things to track with regards to the assumption we make about measuring somebody's blood pressure. So how do we measure somebody's blood pressure? We measure their perfusion to their arm, and we use perfusion to their arm to assume that the perfusion to their brain correlates in some way, shape, or form with the perfusion to their arm. And we generalize that across all human beings. The most important variable to track, in addition to the fact that you are measuring not the blood pressure you care about the most, but a proxy of it, the arm, is to realize that different people have different normal blood pressures, i.e., different people have different thresholds to develop hypoperfusion. As you might have realized, the brain is conveniently the closest or major vital organ to the heart. And there's a reason for that. The reason for that is that it is gonna be the organ that suffers last as a result of hypoperfusion. There are some other caveats to that too, of course. Like there's some organs like the liver that get dual blood supply and so are a little bit protected from that. But it's also really important to remember that somebody who is 9 feet tall will require a different blood pressure than somebody who is 4 feet tall. And if you remember that a average blood pressure is 220 millimeters of mercury to perfuse their brain through a massively large neck. Remember that ultimately, the reason that AMK is open to the possibility that the number that she's seeing on the screen may not indicate the thing she is worried is fundamentally that there still may be adequate perfusion to the brain despite that number on the screen suggesting that there may not be. And the reasons for that are that the brain pressure may not correlate with the arm pressure, and or in this specific individual, the amount required to perfuse the brain is way less than the average human being. And that may be as a result of their height, frailty, adaptive protective mechanisms that they've had from autonomic neuropathy, so on and so forth. And so, at the end of the day, if somebody is wide awake and has a low blood pressure, you can take your time. Because the worst case scenario, the best case scenario is there's nothing going on. The worst case scenario is this number is warning you that something is about to happen, but that nothing right now is happening. So the key thing to try to establish in somebody who is hypotensive is perfusion of the vital organs, as you said. And the most important organ is the brain, by far and away. And if the brain is fine, you have plenty of time. And I just want you all to sit with, as you see more and more patients, the calculations you're doing. You're assuming assuming brachial blood pressure correlates with carotid blood pressure, and you're assuming that the numbers that you've been given as for a general population apply to that patient, and those may not apply for a variety of reasons that AMK already listed. So this is why you will get much more attention to a patient who is hypotensive and is lethargic, sleepy, dizzy, lightheaded, and odds are some of you have experienced transient hypotension before, gotten presyncopal when you got up too fast, were dehydrated, and had vasovagal. You know what it's like to feel that way. And so if a patient's not feeling that way, you have time. You may have no problem at all, or you may have a problem soon, but you certainly don't need to go crazy right then and there. Mental status, mental status, mental status. It's so powerful to see AMK not just be like, okay, you know what, pressures go bonkers. No, mental status is the key variable. Now, the problem with that, of course, is that, as I mentioned to you all, the brain is the last organ to go down. And so the question is, are you going to have the brain go down next? And this is where we love to see the next most important organ, the kidney. Why the kidney is the next most important organ has to do a lot with collateral blood supply and perfusion and blood flow, which we won't spend time on. But if somebody is urinating well and they don't have a reason to have a fake increase in uric output like diabetes, your patient's okay. So we could spend another 20 minutes talking about the significance of the blood pressure, but it really, really is important to remember that you are using a proxy to make a judgment about perfusion of vital organs. And I think as Ethan's case illustrated to us, the patient had absolutely no markers of vital organs being hypoperfused. She was a patient who was found to have hypotension through an arterial blood pressure cuff, who was actually so awake that she was writhing around in the CT scanner from discomfort and maybe agitation from acute intermittent porphyria, and her urine output, as measured by her creatinine on serial days, was completely normal. So what she has is isolated brachial hypotension, not the hypotension that Massa appropriately defined. So let's agree going forward that when we say hypotension, what we really, really mean is perfusion to the vital organs, which goes down in a very predictable manner. Perfusion to the kidney goes down first, and then the brain, for many, many reasons that we can do another academy session on. So if you can establish that the kidneys are fine, I guarantee you the brain is fine too. Oftentimes it's harder to establish whether the kidneys are fine or not. It takes an hour. Watch the urine output, watch the creatinine. So if the brain is fine, you're temporarily okay. And then if you see that the kidney is compromised an hour later, you now know the brain's going to suffer too unless you do something about it. But if you see an hour later, a creatinine comes back, good urine output, you definitely have much more time now, or you may have no problem whatsoever. There are so many people whose brachial blood pressures don't actually correlate with the things we care about. And so it's equally important, I think, in a patient who's hypotensive to know when to go crazy and when to be careful of iatrogenesis. Now, we won't spend the rest of this academy on when to be careful. And I think we'll probably have ample cases to sort of fine tune that reflection. I would love to start off with like, okay, hey, this is serious. The patient's not maintaining, or the kidney function is down and the patient's not going to be maintaining soon. How do we proceed? So let's learn from the other attending in the room. Mengyu, if you have the license to, without the specific details, to believe that the hypotension is real, either because the patient's mental status is depressed, or they're tachycardic, indicating there's something wrong in the cardiovascular system, or they have a Foley and their urine output has been reduced over the last hour or so. I'm really curious what empiric treatments start to cross your mind. You're sort of still like somebody else is on the diagnosis table, um, and you're there just trying to like keep the patient alive. I'm curious what would cross your mind to support them temporarily.
Um, yeah, I think fluid is always the first thing that comes to mind. Although, like, unless the patient has a clear history of heart failure and overt signs of heart failure, like cold extremities, narrow pulse pressure, or like other findings to suggest like a cardiogenic shock, which will go to a different pathway. But otherwise, fluid is often the first choice, like a bolus, and assess their responsiveness. We can also raise the leg as a way. I haven't really done that a lot, but I think that's like a good way to both assess fluids if there's any concern of heart failure, that can also avoid like doing the wrong direction treatment. And I think I would also start, yeah, always start with fluid. Otherwise, beyond that, it's like a matter of vasopressors. Um, yeah, but that would be the next step.
Super, super helpful. Maybe I can squeeze one more detail out of your very large brain. If you were choosing a vasopressor to start, two things that come up for learners are access and then type of vasopressor. What's your take on those two things?
Yeah, in the emergent setting, if the patient doesn't have a central line, I think could start some peripheral vasopressor, and usually the go-to is levofat or norepinephrine.
Amazing. You spoke so accurately and summoned our dear Alex. Hi, Alex. I'm curious, what's your take on those empiric management situations? I imagine you're in them on a near daily basis.
I think that everything that everybody said was 100% awesome, and it was only so long before I could stay away from the hypotension discussion without feeling the need to jump in. But 100%, I think that I totally agree with Maggie. I think norepinephrine is definitely the first line vasopressor for undifferentiated shock. And I think that I really like the ideas that you shared, Mingyu, about ways to look for fluid responsiveness, like doing a passive leg raise, and sometimes you have ways of which basically can act like an empiric 250 cc bolus. And then there are some like nuanced ways that you can look to see if somebody has had a response to those 250 cc's of fluid outside of just an increase in blood pressure, like looking for if somebody has an A line, which usually somebody on the floor isn't going to have, but if they have an A line, looking at the variability in their pulse pressure, the difference between their systolic and diastolic pressures, and seeing with respiration and seeing if that respiraphasic variation has gone from being really high to not being so high. If you have somebody who has some advanced POCUS skills, you can get a measure of that person's left ventricular outflow velocity time integral, which is a little bit nuanced, but basically is a proxy for stroke volume. And similarly, looking to see if that stroke volume changes a lot with respiration, and then after the like a few seconds after a straight leg raise, if it's not no longer changing so much, it may mean that they've had some response to that little bit of fluid. All that to say, though, if you think that somebody is hypotensive and truly hypotensive to the point where they're having systemic effects of it, like as was shared at the very beginning of this academy session, then when in doubt, start vasopressors, and then we can always figure it out later.
I really, really appreciate all the wisdom that all of you shared, especially the final piece, which I think I've noticed increasingly more and more time out of more and more time out of residency, and then more and more data supporting that if you have a good, quote unquote, good peripheral IV, that you can buy time to put a central line in and use peripheral pressors. I think there's a number of times in residency where a pericode hypotensive patient was waiting for a central line to get pressures was way too many. And it's really, really good to hear that we can take at least temporarily take the oomph out of hypotension by buying time by using pressors through a good peripheral line. Um,
And
yeah,
is it okay if I add just one point to that, Rabih?
please, absolutely.
I think I think actually there was a study published out of the hospital where I did my residency that showed that peripheral vasopressors are safe below a certain level. So I think it was the group that trained me at LIJ showed that it was not vasopressin, but and not epinephrine, but norepinephrine and phenylephrine used up to a quantity of about like 10 micrograms per minute, which I think is which is roughly equivalent to like 1 to 2 micrograms per kilogram per minute of norepinephrine. And or if you have reasons why you can't use norepinephrine, like arrhythmia, which might skew you away from it, then maybe a phenylephrine up to, I'd have to double check the exact number, but basically the idea is low dose peripheral vasopressors are okay. And then if you're getting to a point where you need a second one, then you definitely need central venous access.
I love it. I love it. Thank you all so much. Now we have the significance taken care of. Pay attention to the brain. Your kidney is a super sensitive marker. Um, and now that you know that um, most people, and we'll talk a little bit about AMK's concern about AMK and Mengu's concern about cardiogenic shock. Most people, you can give them fluids, and we'll spend some time on that. Yeah, if you're worried about a patient, they definitely need critical care tools and skills and access. But you don't need to not use all the tools that you often already have to temporize until you do so. So now we get to be CP solvers and over intellectualize hypotension. Um, so Siva, maybe we can just start with your reflections. We've had AMK and Mengu and Alex hold their diagnostic thoughts to sort of build the schema together. So I'm curious, how do you think about hypotension in terms of the causes that do so?
Most commonly, I first think of like medications, like medication-induced hypotension, and after that, like if it is an acute emergency, acute drop in blood pressure, I think of hemorrhage, like blood loss, or else like those kind of things. And yeah, that's where my reflex thought will be going.
Yeah, superb. And then may I ask you, when you say medications causing hypotension, what kinds of medications are you thinking?
For example, most commonly the diuretics, like sometimes they are an overdose and like those kind of things, diuretics.
Awesome. So you're thinking diuretics and hemorrhage causing hypovolemia. And hypovolemia, if you take the world and not the United States, hypovolemia is by far and away still the most common cause of shock. Um, Jillian, if we think mechanistically and take Siva's category of hypovolemia and put it aside, what do you think we're left with mechanistically as causes of hypotension?
So I like too low afterload.
Yeah.
So like
Mhm.
massive vasodilation from distributive shock, like anaphylaxis, sepsis.
Perfect.
And then cardiogenic shock, where just like the vessels are fine, you have enough blood and stuff, but the pump isn't working.
Yeah.
And then obstructive shock, which is a little harder for me to say exactly, but
Yeah.
like I guess
Yeah.
there's you can pump, but yeah, I'm not really sure how to mechanistically say what's going on, but you can pump, but there's like a maybe more local problem with excessive afterload. Yeah, how would you describe obstructive
Yeah.
shock mechanistically?
The next 33 minutes of your time are going to be worth it to clarify the most common cause of friction and understanding hypotension. Absolutely super. Yeah. I will tell you that fundamentally, from a very, very simplistic perspective, if you remove all your existing knowledge of hypotension, you'll find it plausible to think of something very, very simple as three simple categories. The simplest of which is where Siva started. There's no volume. None. No volume, no pressure. Very simple. The other issue that can happen in the vessels is there's no clamp. You need not a floppy circuit that has no tone to it. There needs to be some resting tone to maintain pressure after the pump ejects it. Vascular tone. And then finally, I encourage you to toss out cardiogenic and obstructive because there's something really, really simple happening, and there is arrest of flow. That's it. There's a blockage that is not allowing perfusion to continue across the heart. That latter category is the most deadly cause of hypotension for one reason and one reason alone. Hypotension is not just about arterial blood flow, it's about perfusion pressure. Meaning, if I am an organ here, how much juice I get is definitely related to how much is coming this way, but also related to how much pressure there is on the side that is draining me. And when there is arrest of flow, there is two simultaneous hits to perfusion. The first is not unique to this form. It affects every form where there is low arterial blood pressure. The heart, there's arrest of flow in the heart no matter what. And so the blood doesn't make it to the artery. But at the same time, guess what's happening? That blood is building and building and building and building and building in all of the veins, every single one of them. And so now, if you're an organ, not only are you starved of glucose and oxygen coming in from the arteries, but you can't even move any molecule of oxygen and glucose back into the heart because now there's so much resistance on the venous side. There is no such thing as normotensive septic shock. There is no such thing as normotensive hypovolemic shock. But you will find that roughly 20 to 30% of patients who have cardiogenic shock are given the label normotensive cardiogenic shock. How can you have shock with a normal arterial blood pressure? And this is the beauty of beginning with AMK's reflection. AMK was like, just because you're hypotensive on that monitor doesn't mean you're hypotensive, really. And here I am now, exactly 30 minutes telling you, just because you're not hypotensive on that monitor doesn't mean you're not. You could be. And the uniqueness of the arrest of flow creates two mechanisms for you to choke off your organs. One is the mechanism that unites this entire space, hypotension. But the unique mechanism of the arrest of flow is pressure and pressure and pressure and pressure building up on the venous side, impairing your perfusion across an organ. You have a low arterial pressure and high venous pressure, making your normal artery pressure ineffective. I read a case report in somebody who had normotensive cardiogenic shock, who they had hepatic venous pressures on. The arterial blood pressure in that patient was 60s, and their hepatic vein pressure was 35. So even though their map was 60, not too bad, 65, almost there, their actual perfusion pressure was 30. Horrible. So remember, what we really care about is perfusion, as Masa said, to the vital organs. Perfusion of the vital organs is not just about how much arterial blood flow they're getting. It's also about how much venous resistance there is. And the good news is, in hypovolemia, there's no venous resistance. The veins are also empty, just as the arteries are. The good news in vasoplegia or vasodilation or loss of tone, the veins and the arteries simultaneously lose tone. So the venous pressure and the arterial pressure are both low. And so even though you're getting sluggish flow in those two mechanisms to the organ, at least there isn't a wall of high venous pressure that you have to climb to make it to the other side. The good news is that arrest of flow is pretty rare in the United States. It accounts about 15 to 20% of all shock. But now you know it's by far and away the most morbid. And so here is unfortunately the lie and the inaccuracy of this entire spiel. I said it's hypotension, but that's not true. As we learned from AMK, hypotension on a monitor may not be actual hypotension. But also the premise there is that we're speaking about the arterial circulation. And I hope you're realizing that the single most important thing when you're trying to figure out diagnostically about why somebody has arterial hypotension is to try to figure out what's their venous blood pressure. So see me, let's practice, okay? So in septic shock, what do you think the venous blood pressure is? And the good news is you only have two options, low or high. So in septic shock, what do you think the venous blood pressure is?
Maybe I think it will be low.
Excellent. Even though it is 12:30 a.m., your brain is working very well. Let's see how far you can take it, okay? What about hypovolemia?
Maybe I think it will be low since there is no blood in the body.
Excellent. And what about in the arrest of flow?
Maybe it will back up, so it will be high.
Exactly right. Exactly right. So if you could do like a magic trick and walk into a room with a patient with hypotension, and you would be like, oh, venous pressure, tell me what it is. Mm, high. Oh, okay, I know what's going on. There's arrest of flow. That tells you the problem's in the heart. If the venous pressure is low, now you know the problem's in the vessels. Either they're empty or they're not clamping. Now, how you go about measuring that venous pressure is very, very complicated. You can actually literally directly measure it in many ways. You can infer by visualizing it in many ways with your eyes, with POCUS. But I will tell you that you can often tell when you walk in the room. Often tell that that weight of that venous column is felt here. We've had an academy session on what lightheadedness means. Lightheadedness is essentially arterial hypotension. And I've shared with you all, and I'll try to find it and refer it in the chat, how when somebody is dyspneic and lightheaded at the same time, it's a horrible combination. Because if you're dyspneic and you're lightheaded, it means you're not perfusing your lungs or your brain. That means you have arrest of flow. There's some rare exceptions to that, or unusual exceptions to that. But I will tell you that every single time I've walked into a situation where somebody has arrest of flow, they don't just have a brain problem, they have a chest problem. And when somebody very smart and skilled puts a POCUS on them, or when we do all the exam maneuvers to study the venous pressures, they're all layered upon the observation of the presence of resting tachypnea in almost all of them. Because they're not just having an issue perfusing their brain, they're having an issue moving things through their chest, and they don't hide it. In fact, I guarantee you that they don't hide it because this is the most severe manifestation of end-stage diseases that always begin with shortness of breath. If you take the very disease that is causing arrest of flow in the heart and you tamp down the severity, how does a patient come to you? They come to you by telling you they cannot walk without getting short of breath. And you can spot that with your very own eyes, and you have now the most serious manifestation of that disease. It's not going to go away. It's going to be even more obvious. And now, of course, it takes a lot of training to build that pretest probability. And of course, you know that just because they're short of breath doesn't mean they have cardiogenic shock. They could easily have pneumonia with sepsis physiology. But it is a nearly 100% sensitive test for the presence of arrest of flow. It requires experience and observation and not to get distracted by the room. But if somebody is hypotensive and their respiratory rate is 12 and they're breathing comfortably, I think I have a very strong hunch as to what the POCUS is going to show and what the physical exam is going to show. We're spending a lot of time on this space of arrest of obstruction because I think it's the one place where you might have some hesitancy about your fluids. You're going to give pressors, but you're like, hey, could this patient have arrest of flow? And what if I pour fluid in them and the only way I can pour fluid is I can't pour it into an artery. That doesn't work. I have to pour it into their vein. Isn't their venous pressure already high? Am I not going to make it worse? And the answer is no, with one major exception. And to understand that, I think we have to zoom in a little bit on what we mean by arrest of flow and answer Jillian's question. So Krishna, back to your sort of fundamental understanding. Somebody has somebody has arrest of flow causing hypotension from a pulmonary embolism. Of course, you have much more specific treatment to offer them, as we did in Bettina's case. But do you think fluids will be helpful or harmful in a patient with PE presenting with arrest of flow?
I think like because PE is associated with increased venous pressure and increased preload, and the only thing that we would be doing by adding fluids to a person who's already having high preload is congest them further. Fluids would not really benefit the patient's hypotension or shock.
I think that line of reasoning is at the surface seems very logical. But maybe Alex, you can share with us what your observations are. So somebody has acute pulmonary embolism. How do you feel like fluids might fare in your real life or hypothetical life experience?
I think a concern is that if they truly have impending right ventricular failure, that then you can basically throw them off their Frank-Starling curve. So if you think about your like basic med school physiology that you might have learned about there being that very final phase of your Frank-Starling curve where when the actin and myosin fibers are so stretched that they no longer properly overlap, then maybe then if that right ventricle was just squeezing enough to get fluid past that obstruction, and then that ventricle becomes even just a little bit more distended, and you have just a little bit less squeeze, then maybe you could throw this person into true like myocardial collapse. There's often so much going on with these patients that it's hard to know exactly what tipped them over the edge. But so a lot of this is admittedly theoretical, but that is some of the thought.
Yeah. And I think you outlined the tension, and hopefully we can take a moment to explain it. So Krishna, if you take for granted what happened to Bettina's case is that she had an acute pulmonary embolism, right then and there. If you imagine that there is a blockage in the circuitry, but your pump is intact. If you give your pump more ammunition, it can maybe dislodge that blockage or work against that blockage. The filter of cardiogenic versus obstructive shock is actually a very simple concept. It's asking, in this mental model of arrest of flow, is my ventricular contractility impaired or preserved? Let me give you the most incontrovertible evidence that fluids help some forms of obstructive shock. In fact, fluids are probably the mainstay treatment of let me give you an example of how in a arrest of flow situation, fluids are the only life-saving treatment, really. And that's LV outflow tract obstruction. So when you have LV outflow tract obstruction, you have collapse of the left ventricle, outflow tract. The actual LV beneath the outflow tract is super healthy and in fact hyperdynamic. And if you give the patient fluid, you arm that hyperdynamic LV with more and more force, more and more blood goes through, and boom, you fix the LV outflow tract obstruction. And Kara presented a case that happened to her in her ICU rotation where a patient just became hypotensive. They couldn't figure out why. Fluids. Healthy LV, plopped open that LV outflow tract, patient's fine. The tension is that in other forms of obstruction, it really depends on whether your ventricles are healthy or not. So in a hyperacute pulmonary embolism, the RV has still not ballooned out and is still healthy. You have the chance to overpower it and give the patient fluids and see what happens. In fact, at least as of the guidelines 2 years ago, Alex may know more. In order to call somebody as having a hemodynamically significant pulmonary embolism, you had to give them fluids and prove that they actually had sustained hypotension. So that tells you the notion that the RV, if given more ammunition to fight against the blockage, can do so. But what happens if the RV, because of working really, really hard and building up more and more volume, starts to fail? Then giving it fluid is a problem. So I'll give you a very simple way to think it through. If you have acute arrest of flow, fluids is the way to go. Unless that acute arrest of flow is a massive myocardial infarction, where what's happening acutely is a complete loss of muscle contraction. Good news is that's very easy to spot. You have a wonderful tool called an EKG that can detect massive myocardial infarctions with relative ease. So as a good general rule of thumb, if you, as was true in Bettina's case, have a patient who has sudden severe arrest of flow, fluids is the way to go. Cardiogenic shock is typically a term used for patients who have a slowly progressive, over the course of days, form of shock that accumulates as a result of myocardial dysfunction. And when you look back upon those patients, you'll see that they actually did not have abrupt arrest of flow. They had slowly failing transfer of blood from the venous to the arterial circulation. And in those people, they've accumulated so much volume in their chambers that you're adding in a liter or two is best case scenario not going to do anything. Worst case scenario going to add to the venous pressure. So fluids are great for pathologic vasodilation. Fluids are great for hypovolemia. Fluids on the surface seem like a bad idea for arrest of flow because you're adding to the venous hypertension. But if you're adding to a healthy pump that just has something in the way, potentially what you are doing is arming that pump with more force to be able to dislodge or move out, push against the pericardial effusion, push against the pulmonary embolism, and push against the LV outflow obstruction. So if you have a sense that this happened acutely and your patient's blood pressure was previously normal and they plummeted, fluids are a very, very bad idea, a very, very good idea. The only times I don't give fluids is when I get a sense that this patient's hypotension is not acute, that actually they've been smoldering. And that's the time where, gosh, giving fluids is probably not a good idea. So as a default hypothesis, what happens when I see real deal hypotension and I'm worried? I have no qualms about running up to 10 mics of Levophed through a good peripheral IV. I'm trying to see if the patient has a thoracic syndrome as evidenced by shortness of breath at rest. And if they do, I pause. And I ask myself, do I know the time course here? If the time course is acute and but it's acute, oh my gosh, that's a PE, rapidly progressive pericardial effusion, or outflow tract obstruction until proven otherwise. And I have no qualms giving them a liter of fluids. But if they're brewing, if they've been brewing for a few days and show up to our ER, ooh, that's scary. That's the worst kind of shock. So let me stop there and see what questions you'll have. Yeah, Siva, please.
Dr. Rabi, I have one question. Like, if the patient has acute hypotension and the RV function is preserved, we can give fluids. So, for instance, just hypothetically, like acute hypotension with the patient has AKI as well. So usually when we increase venous hypertension, the net filtration will decrease and the kidneys will not able to filter, right? So at that instance, can we give fluid or not? Because we have to remove the fluid, right, to decrease the venous hypertension in
Yeah.
people with concomitant AKI because of
If
the
some if somebody has AKI, that tells you that the time course is not acute. If somebody truly has an acute obstruction, the probability of renal dysfunction is very low, as at least in renal obstruction from the venous congestion. Very, very low. So you might be dealing with a situation. Well, I should just sort of emphasize that in order to, I guess the simple concept here is in order to have meaningful venous congestion, it really needs time. And I don't have a good number for you. I'd say just based on clinical experience alone, by the time somebody has a meaningful rise in their venous pressure, it's been probably at least a day. This is why you'll see that in a patient who has tamponade, a jugular venous distension is a very well described phenomenon, right? See distended neck veins, Beck's triad is part of that. But you'll see very few people describe jugular venous distension in acute pulmonary embolism. You'll also see people have struggled to describe jugular venous distension in patients who have outflow tract obstruction from hypertrophic cardiomyopathy. So if you are having venous distension significant enough to cause your neck to distend or your kidney to impact, you're probably now beyond that acute phase, and you're probably in that situation where now the myocardium is not happy, in which case you're right that fluid removal is the name of the game. So I would venture to say that if the kidneys are feeling the venous pressure, that tells you that the heart is no longer able to transmit the pressure forward and instead is sending it backwards, which tells you that your fluids are probably not a healthy strategy.
Got it. Thank you, Dr. Ravi.
For sure. Now, if this space is like new to you, you'll have to like reflect on this, watch this over and over again. The simple premise is an acute circulatory obstruction, the heart itself, unless it's been impacted by an MI, is still healthy and might benefit from you giving it more tools to do its job. But if the obstruction or the dysfunction of flow has been accumulating for some time, the heart is often intrinsically impacted and unhealthy, in which case giving it fluids may not be a good idea. Krishna, I thought I saw a hand. Yeah, go for it, please.
I wanted to ask about something that Alex also pointed out.
Oh, yes.
Is how do we look for fluid responsiveness? Alex, you said a very interesting thing, which is like passive leg raising. The thing is like every attending that I spoke to in the ICU has always said that, okay, passive leg raising is good and we can do it. But the thing is like, how do we actually do it in the ICU is a question. And I used to think that like you can just raise the patient's leg with your hands, and that should be how you would do it. And even if you were measuring the stroke volume with VTI and things like that, that's how you would do it. But apparently that's not the best way, and it's not the most ideal way. And you should have the patient, the entire bed itself raise at a certain speed to a certain angle for you to properly get the assessment of fluid responsiveness. So I wanted to ask, like, especially in the case of like obstructive shock, where like we can try some fluids because the RV is still functioning. How do we know? How do you actually use responsiveness? How do you actually test for it in your day-to-day practice?
Yeah, Alex, I'm curious, what do you do since you do this the most?
I think what I would say is if it's a little bit different in the ICU when we have somebody with an evolving clinical condition than it is when you're called to a rapid response, for example, and or patients being rolled into the ED and you really have no idea what's going on with the patient. I think that to your question about a patient with obstructive shock, I think that I think it's more common in the ICU that we have somebody with progressed obstructive shock than it is that we have somebody with like a really acute PE, because probably that person, as soon as that acute etiology has been identified, they've gotten whatever treatment they've needed before they came to us. I think though, if I have somebody with like a known pericardial effusion and I see that they're slowly that their hypotension and their organ failure is evolving, I'm probably, rather than looking for fluid responsiveness, I'm just giving that patient fluids while in the meanwhile calling whatever consultant I need to try to get that person an intervention to evacuate that fluid from their pericardial space. And similarly, if I have somebody who has like an unknown P or an evolving or what I believe to be an evolving P, I'm sort of throwing whatever I can at that patient to stabilize that person before I gather whatever resources I need to give that person TPA. Um, I think the times when I'm really looking to evaluate fluid responsiveness are when I have somebody who has like vasoplegic shock, for example, and that person has gotten their that roughly 30 cc's per kg of fluid resuscitation, and they're still on vasopressors, and I'm trying to decide, do they need more fluids to get them off of vasopressors, or I have a person who's been on who has kind of seems to be coming out of their shock state, their organ injury is recovering, but they're still on that like 2 micrograms per minute of norepinephrine, and I'm trying to figure out, is there a way to, it might giving them fluids to allow us to more quickly get them off of that vasopressor. And I think that the way that I would do it for that patient is, um, and I think some of the inherent tension that you expressed, Krishna, in terms of like how exactly do we go about the leg raise, how exactly do we look for fluid responsiveness, is that it's a big topic, and there are some, definitely can send over some resources to help you identify what exactly are like the most literature approved ways to do it. But I think, as is the case with just about anything, there's a literature approved way, and then there's the way that we practically do it in clinical practice. So, yes, somebody should be on an 8 cc per kilogram of ideal body weight tidal volume in order for us really to assess if they're having fluid responsiveness based upon an arterial waveform change. But in practice, I'm not changing that person's tidal volume in order to do it. Yes, that lift of the leg should be at least 15 degrees, and it should be for at least 10 seconds. But when I'm rounding on 15 patients in the ICU, am I really doing that, versus am I making somewhat of a gestalt? So all that I apologize. That was a little bit of a drawn out answer, but I hope that that was helpful. I'm curious to hear what your thoughts are, Rabih.
No, it's so practical, and so I'm so glad you were just real. I think the data is meant to help us understand what things would be in an ideal circumstance. I see Jeffrey here. It's like diagnostic criteria for research purposes in rheumatology, like how you diagnose research lupus on paper versus how it actually happens in real life and how it doesn't happen in real life. Yeah, I think we're at the hour, so I'll just take a moment to share. With these academy sessions, often it feels like a topsy-turvy course, and so um, if you're like Alex and a pro, you learn nothing new and maybe just got the chance to articulate yourself. But if this is new to you, I think you really have to remember that the monitor is a monitor of the arm and may not correlate with the brain, and that even if the monitor is normal, if you have high venous pressures, you're only getting half the story. The hardest part about shock is when there's arrest of flow across the heart. If it's acute, you probably will help the patient by giving them fluids, and we call that obstructive shock. That's really what obstructive shock is. It's really an acute arrest of flow that leaves the myocardium healthy. There is no cause of obstructive shock with unhealthy myocardium. And that's the distinction, Jillian, between cardiogenic obstructive. What is the health of the RV and what is the health of the LV? And if you have a large tension pneumothorax, a large pericardial effusion, a large pulmonary embolism, outflow tract, you can take that heart, transplant it into somebody else, and it will be glorious. And that's why we single out obstructive shock from cardiogenic shock, because obstructive shock has nothing to do with the actual pump power of the heart. And when that pump power is preserved, you can temporize with fluids. And as AMK said from the beginning, if you have arrest of flow with preserved pump power, you need a needle. Because if there is adequate pump power and yet there is no flow across, that means there is a mechanical issue, either in the pericardium, in the pulmonary artery, or in the chest. The only cause of arrest of flow with preserved pump power that isn't mechanical is hypertrophic cardio, is LV outflow tract obstruction. That's why KRSK stumped me. I was like, oh my gosh, I know what this is. This is acute arrest of flow. Where's the mechanical issue that I can fix with a needle? Oh, CT chest with contrast, no PE, no pericardial effusion. My, no pneumothorax. Where is it? LV outflow tract. So that's how we break down cardiogenic and obstructive. We ask a very simple question. Is the LV and RV healthy? If the answer is yes, then the lesion must be a mechanical issue in and around the heart, but not the pump itself. Those patients love some fluids. Patients who don't are people whose LV or RV are unhappy and they have cardiogenic shock. And unless they just had a massive MI right in front of you, they've been brewing for a while. So who gets fluids? At the get-go, everybody except those people who have venous hypertension from arrest to flow who've been brewing for some time. Everybody else. And now that you have a simplistic model of arrest of flow, is the myocardium unhealthy, cardiogenic, or is the myocardium healthy, obstructive? I'll offer you a simplistic mental model of the vascular causes of shock for us to play around with in the future. All of distributive shock comes down to finding what substance in the body is causing pathological vasodilation. And it's a hunt for that substance. That substance may be present in excess, like cytokines in sepsis or histamine in anaphylaxis, or Entresto in patients who take too much of it for their heart, or sneakily, it may be a deficiency of cortisol or a deficiency of some other substances which we've seen, like scurvy and thiamine. But what you are looking for in somebody who has pathological vasodilation is what molecule is vasodilating everything. There is nothing that can take the entire vascular system and make it do this apart from a substance. And what you're trying to figure out is what that substance is. And the good news is it is boldly staring at you in the face. But you just have to know how to look. High fever, urticarial rash, medication list, perifollicular hemorrhages, buccal hyperpigmentation, salt craving. It's there. Sometimes it's much harder than others, but it's there. Hypovolemia is the simplest of them all. There is a hole in the cardiovascular system, and that hole is leaking. How big is the hole determines if it's a hemorrhage or a non-hemorrhagic form of volume loss. And if there is a hole in the cardiovascular system leaking so much fluid that the patient's hypotensive, you should find it effortlessly. Gushing out into the world from trauma, uh, coming out of the GI tract, gynecological bleeding, so on and so forth. Just like adrenal insufficiency, though, there are places where you can have holes that are harder to spot. And the short answer is belly, 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 belly. You can lose so much fluid into your belly that a lot can go unaccounted for. It's also true that it can happen in your buttock or your thigh, but if you're looking good enough and you know to look in the buttock and the thigh, you'll spot it. So if you've looked and you found nothing, it's in the retroperitoneum. There's also a place that you can use a lot of fluid without realizing it, and that's the kidney. Unfortunately, as we talked about yesterday with hypercalcemia and as patients with diabetes unfortunately present in HHS or DKA, they lose a lot of fluid to their kidney and urinate a lot, and they don't know that that is causing volume loss. So what is hypotension? Hypotension is either empty vessels from a hole in the body, usually readily apparent, but if not, hiding in the belly or coming out of the kidney. Or if it's not empty vessels, it's pathologically dilated vessels. And pathological dilation only happens because of one word, substance. What is it? If, however, you are dealing with the most dreaded cause of hypotension, where you have the dual hit of venous hypertension and arterial hypotension, you care only about one thing. Is the myocardium healthy or not healthy? And if it is, this is obstruction, give it fluids and find the mechanical issue. If the myocardium is unhealthy, your patient's in a lot of trouble. Because unlike plugging a hole for hypovolemia or removing the effects of a substance in distributive shock or undoing a mechanical blockage, when you have cardiogenic shock, your ability to revive that myocardium is really, really, really impaired, which is why these patients often do the worst. And that's hypotension for you. We have a lot more to revisit each category in the future, but hopefully it gives you a little bit of building blocks to think it through. And I'm sure we'll have many more sub conversations about different elements of it. I'm going to stop the recording, and then if anyone